he suddenly realized, and this is what's important, he suddenly realized that he could break through, not that the therapist could break through. And this reaffirms a concept made a number of years ago by the analyst, well known, I suspect, both in Europe and the United States, although he's an American, Abraham Kardner. Abraham Kardner today is about 93 or 94 years old. He was first analyzed by Freud. But Kardner has frequently expressed the idea that no patient is freed of neuroses until that patient can experience self-mastery. And that too often therapies deny patients self-mastery. And many therapies, not necessarily hypnotherapy, but many therapies emphasize therapist mastery, therapist ability to cure the patient. I think all therapists, good doctors, have the great desire to cure patients. But in doing so, they get caught up with being the more masterful member of that alliance. And I think in psychotherapy, more so than in any of the other healing disciplines, we have to give the patient the sense of self-mastery, the patient the sense of self-healing. He must have that power. And it is this self-directed sensory process that permits self-mastery to emerge, not always in one session, and there were many sessions before this, obviously. But from this point on, there was a breakthrough. And, for example, some of the language he used here, he never would use outside of hypnosis. He was too constricted. He was too contorted, too convoluted. But in giving him this regressive sensory experience, he was now able to make this great lurch, this great jump, as he himself described it, in better words. And as you can see, it would be very hard for any therapist to describe in language the real experience that this man went through in terms of the kind of language he organized. And that language is a real index of what he was experiencing. One has to, for its full concept, hear it, because it has intonation, it has affect, it has emphasis, it has theater. And you know, it was Sargent, the British psychiatrist who worked during World War I with abreacted experiences, who said that abreaction is really theater. It's theater with all the drama of theater. And that if we do not produce that in neuroses, we will never cure or free a patient. And to some extent, this kind of breakthrough is necessary. I'm not in any way implying that there are not other ways of getting these breakthroughs. And I wouldn't say that there aren't other therapies that can do it. Of course they can. It seems to me, from our experience, this is a much more direct and a simpler method. It is not very complicated. It is so simple that someone sometimes says it's almost on automatic pilot. Once you have focused the attention and the sensation and the involvement, what comes out almost ceases to come out. And it has different forms. They're not alike. For example, if I can indulge you a little more. A 27-year-old married woman was seen at the recommendation of her physician and priest. She was severely depressed, increasingly dependent on alcohol, and involved in a great deal of promiscuous sexual behavior. During 2 initial consultations, she found it almost physically impossible to talk. If it had been a classical analytic situation, we would have had a 50-minute hour of silence. She said nothing. She simply presented herself and said, "I'm here because my doctor and my priest said I have to come. I have trouble." That was all she would say. That's all she could say. During 2 consultations, she was encouraged to say a little bit, but very much lacking. She couldn't even verbalize answers to direct questions. Sometimes, I can remember, she was asked, "When you have an extramarital sexual experience, what is it that makes you feel you need to have it?" She didn't indicate she didn't wish to answer. She just said, "I don't know." And that was the end of the conversation. The 3rd session involved hypnosis, in which all of the attention focus in hypnosis was on sensory imagery. She was told that she would visualize her body, and that she would not only visualize it, but she would be able to feel it, and that she would be able, and again the language is firm and direct, it doesn't matter how accurate it is, that she would be able to visualize it, she would be able to sense it, she would be able to smell it, she could touch it if she wanted, she would be in contact with almost every cell in her body if she wished to. Always the permissive aspect, but at the same time, a firmness, so that if one wants to use a metaphor, it is a firm but gentle approach to saying, this is what you must do, but you have the right to negate it if you want to. She was told that she would be able to sense everything that was going on within her body, not her mind, just her body. No verbalization took place during 45 minutes of hypnosis, not a word. In one of the modifications of this therapeutic procedure, we have an adjacent room to our treatment rooms in which patients, after they're dehypnotized, can go into the room, and there is writing material, there is paper for drawing if they wish to, there's a tape recorder for talking into it. In other words, they can report in their own privacy anything that they now are aware of that they have not stated or described during the immediately preceding session. She went into this room, this soundless, uncommunicative, silent, depressed, withdrawn, detached, really quite alienated 27-year-old woman. And this is what she wrote. Actually, she didn't write it, I'm sorry. This is what she dictated onto the tape recorder. She really didn't have the energy to write. That's why she probably did not use pen and paper, but simply pushed the tape recorder. And this is what she said. A demon dwells within me, casting shadows upon my days, destroying any hope to be, relentlessly gnawing its prey. Day and night it torments, tortures, like a cancer, rotting to the bone. It will not leave me alone, not a minute, not a second. Seeping through all my veins, it paralyzes, terrorizes, to unfathomable depths. A veritable hell lies buried in this putrid piece of humanity, rudely destroying everything it nears, spreading vengeance, hate, hurt, haunting all it reaches. I can tear at this flesh that houses this monster called me, so ugly and hateful, and objects everything that it is, not worth a damn to anyone, to anything. It should be mutilated, it should be smashed to pieces, it should be thrown to hungry wolves before it permeates to greater lengths, before its vileness taints everything. Frightening feelings are these, compelling, lurking all the time, very close at hand, a pitiable state to be in, to loathe so much as to reach this degree and intensity of self-hate, to want to inflict such pain and horror because there seems no other answer, no place to put yourself, no joy to feel, no satisfactions obtained, nothing to hope for, nothing to live for, constant frustration, turmoil, growing by leaps and bounds, the omega of futility and fruitlessness. After 4 more sessions of this kind of sensory focus, she went into the room, and this time she used a pen and paper, and she wrote a poem. Warmth pervades the atmosphere. Someone to talk with beckons as you near. The eyes you watch, serene and fine, you know will treat you, oh so kind. The voice you hear, sincere and true, you know will open your heart anew. No need to pretend, no need to amend, for now you do not have to flee. The hurt you have felt, the torment once hidden, the tears, the fears, repressed for years, flow steadily through, until you can find the self lost to you, who you never knew. Now, the above material reflects the verbal and imagery activity which stemmed from the interlocking with sensory functions. This woman went on to make considerable use of continued therapy for only about 3 more months. And follow-up studies revealed that she was functioning again very well, resumed her family life, went back to school, and became a registered nurse eventually. And the last we heard, she was a psychiatric nurse working with schizophrenic patients. These are some of the fragments of the kind of material. The thing which is striking about all of the material, as one reviews thousands of hours from different therapists of the procedure. And I emphasize different therapists for the reason that if one therapist can produce one kind of material and one kind of responsiveness, that's fine, but that indicates an artist. And psychotherapy is an art rather than a science, at least at the present time. And there are some therapists who are better artists than others. But what we need for the base level of operation are people who are not great artists, but who are good therapists and who can use solid strategies and techniques to help a wide range of patients consistently and steadily. There will always be geniuses, there will always be great artists, and many of them are not trained in the art of psychotherapy, but they have a great knack for helping other people. They may be priests, they may be in all callings of life. But those are the exceptions, and that's not what is our concern. We get consistently this level of linguistic flow and linguistic structure and the externalization of internalized feelings that have been inaccessible up to this time. And as you can see, there is a level of integration that in itself reveals an emerging sense of self-mastery and self-integration. In other words, from a quiet, withdrawn, alienated self, you're suddenly getting an integrated self who can see the negative parts with the positive anticipation and expectation of recovery and of gain through her efforts, through her own efforts, who begins now not to attack herself, but to analyze herself. And the analysis is hers. It's not the therapist's interpretation. As you notice in this rendition in both cases, there is no interpretation presented. There is no therapeutic interpretation. This is simply the patient's presentation of what they are experiencing. And they're experiencing it at a very complex level. And the complexity is to be derived by an understanding not only of the language, and the language is most meaningful, but as I say, the affects, the manner in which that language is conveyed, both in its structure, in its syntax, and in its meaningfulness. So that it is for this reason that we have been very encouraged by the consistency of this kind of approach in really freeing patients of those resistances, of those repressions that make it virtually impossible to break through in more conventional psychotherapy and even in more conventional, and there is conventional hypnotherapy. There would be little way of breaking through some of this with positive suggestions. But by unlocking her unconscious, by triggering her unconscious, we gave her and the gentleman I read before the ability to do this on their own. And even though they may not always make reference to doing it on their own, they know they're doing it on their own. And they have a sense of power that begins to emerge from this, a sense of not being helpless. And probably anybody who has been a therapist knows that patients trapped in the dilemma of their neuroses suffer from many different issues in terms of feelings, but one is paramount, and that is the sense of helplessness, the sense of not knowing how to deal with these feelings, of not knowing how to get out of them, and hoping that somebody will do it for them, which is very difficult to do. All right, if there are any questions, I think we could take them. I've been asked to stop at this hour.
Si parla tu, dopo parlo io.
È giusto da parte del terapeuta dare un'interpretazione comunque positiva, anche se non sicuramente molto scientificamente vera, cioè è valido interpretare in modo positivo anche se non siamo sicuri che l'interpretazione sia quella più giusta.
Interpretation is a very delicate issue, as you have just described. I think very often patients do not interpret their material, they describe their feelings and their associations to it. I think if there is some aspect of that association or that description which seems to be counterproductive or at variance with aspects of their managing their own feelings, then I think the therapist should attempt to clarify the meaningfulness of that dream. If, on the other hand, there seems to be a thoughtful and productive association, a thoughtful clarification of what feelings are present, and if there are feelings that come from the dream, then I think they are best left to the patient's own management. As Sullivan has said, really sometimes the greatest damage we do to patients is by too rapid interpretation, and by interpretation which comes from the so-called sophisticated insights of the therapist rather than the feelings of the patient. So that interpretations should be given cautiously, they should be timed appropriately, and very often I have found it useful to withhold interpretation of material until some later point in the patient's own development of self-understanding, until their insight has evolved into a more mature and more reality-oriented perspective. At that point, to go back to some earlier material and remember the dream you had 2 weeks ago, or remember the dream you had a month ago. Let's take another look at that. And then with some assistance and some help, I think very often the interpretation should be a joint process, rather than, in the more traditional sense, an authoritative interpretation. This is what it means. You know, it's like somebody taking a sample of urine to the laboratory and then somebody reading the report and saying, well, look, this is what they found in the laboratory. This is the analysis. Well, I think that kind of interpretation can be very harmful. And I think more and more we're leaning away from premature interpretations. I would, however, agree with something you implied, although you didn't state it, or at least I didn't understand it as being stated that clearly, but it was clearly implied. I would avoid negative, catastrophic, traumatic interpretations, even though they may be implicit in the patient's productions. Some of the productions I read today were generally freeing productions and very positive ones. There are times when one is caught in the midstream of this and what comes out is very conflicting and very traumatic and upsetting. I think at that point, rather than interpretation, one gives some clarification which holds out hope for further understanding and further insight into this process without implying that one is stuck. I think the greatest danger lies in leaving patients with the feeling that they are stuck with this. I think so long as they have the sense that they are sharing this with you, that they are in an alliance with you on this, and that even if it is not as yet fully resolved and understood, that it is going to be, then that in itself is sufficient interpretation. But again, I kind of paraphrase Sullivan, and we'll go a little more into that. Many problems that patients have are resolved rather than interpreted. And I think our ultimate goal in the treatment of neuroses particularly is the resolution of conflict, not necessarily the insightful sophistication of the understanding of that conflict. I think we want it resolved. We don't really care that they understand it the way we understand it or the way we think we understand it, so long as it is resolved. And I think working through that process of resolution is what hypnosis is very effective at, because the support that comes from the hypnosis and from that relationship and that hypnotic transference lends itself to giving the patient the strength, the confidence, and the expectation of recovery on their own, and the fact that resolution is at hand, and that they're not doing it totally alone, but they have support, but they are doing it through their efforts, and their efforts take on meaning and value for them. I don't know if that answers the question or confuses and muddies the waters.
Prendo io. Do una risposta anch'io.
Con cui è nato e si dice una fesseria, perché il bambino nelle prime 72 ore non può vedere, è risaputo questo. E io sono d'accordo col dottor Kline a vedere in una maniera molto critica tutti i casi in cui si parla di regressione di personalità e di modo con cui nella regressione della personalità sono stati visti alcuni avvenimenti, soprattutto quelli prenatali. Già quelli del primo anno vanno visti con estrema cautela, soprattutto perché la possibilità sensoriale del bambino di poter accumulare delle immagini e dei ricordi è un po' limitata. Ma nei casi prenatali è chiaro che sono assurdi e fanno parte i ricordi soltanto delle fantasie del soggetto. Grazie.
Riferisco brevemente il caso riportato da un vostro collega anestesista. Il dottor Gazzoni, questo è un altro, aspetta, no, adesso per dire, questo è un altro. Aveva fatto la regressione di età a una giovane di 19 anni circa. Questa voleva regredirla fino a 3 anni, gli era sfuggita il controllo ed è regredita fino alla vita intrauterina, al momento proprio del parto. Questa si lamentava con voce soffocata, che lui poi ha registrato tutte queste frasi che ha detto, che c'era una massa biancastra che le impediva di uscire alla luce. E all'insaputa della paziente si è recato dalla madre della paziente stessa a domandare qualche chiarimento e dice: mia figlia non lo sa, le ho voluto evitare anche un eventuale trauma, ma è la seconda gemella di una nata morta che le impediva di uscire. Ora, se ci siano queste sensazioni di captare immagini o altro, è tutto da verificare, è tutto da vedere. Quando ci sono delle conferme, le conferme vanno, diciamo così, tenute in una certa considerazione e non scartate a priori. Ci sono delle sensibilità particolari.
Aggiungo qualche cosa.
Non può vedere, non vede, non può che cosa dire.
Può darsi, ecco, un'ipotesi, che malgrado ricordiamo, la regressione di età non porta il soggetto a diventare piccolo e appena nascituro. Quindi la personalità è intatta e può darsi che essa dica la personalità del paziente nella sua situazione attuale quello che non era capace di vedere allora. Questa è l'ipotesi. Scientifico non c'è niente, ma però di ragionevole accreditamento c'è, e mi pare di aver dato una soddisfacente risposta.
I think there are valid points that have been expressed on both sides. I think what we must bear in mind is that age regression is part of a total regression. It's part of a regression in terms of cognitive and perceptual mechanisms. And while there may be some very actualized memories that are imprinted, that are recalled in some instances, in others, like with patients with amnesia who begin to recall things for which they've been amnesic, they recall things at different points and then they have to add things in between to make them connect, and they make up those things. The difference between the amnesic patient and, in my opinion, the hypnotic patient is that instead of just making them up, they sometimes incorporate things that have been told to them at very early age levels, that have been read to them, that they have heard, that they have perceived. So that I think there is authenticity on both sides of this issue. Some age regressions may be very accurate and may actually revivify what has precisely taken place. Others have great emotional significance, even if the specific recall may be interlaced with material that is imported from other associations and identities. But I think, as you have expressed, we must be critical of what is going on so that we can maintain our objectivity and not be incorporated into it. But it is certainly, you know, on both sides, there is a good deal of authenticity, and we need a balanced approach to what is involved. I might add that in terms of the centrality of regression, for those of you who are involved in doing a